is actually defense or barrier. Absorption allows stuff to go, barrier function prevents it from going in. So if you look at all these barriers that we talked about, what are these barriers? Mechanical, chemical, immunologic functions. So first one is the microbiology. So if you look, this is the intestinal lumen, and this is the intestinal epithelium or the cell that we talked about. These are villi and microvilli. Actually, these are microvilli. So in the intestinal lumen, there is first layer of the actually mucus, and mucus has two layers. One is little light, other is little dark. So thin layer, thick layer of the mucus. The second is, so first one is this bacteria, second is this mucus, then the third part is this intestinal epithelial cell, and then if things go through it, then there are blood cells which are lymphocytes, they fight off this bacteria or whatever came in. The other one, blood vessels, and suppose everything go through it and the blood go to the liver, so the liver is the last barrier where everything will be filtered. Suppose it goes to the intestine. So we'll actually talk about these different barriers and see what might be the problem. So if we look, intestinal permeability, it allows only certain things to go, not everything. And so first thing, let's just talk about intestinal barrier. People talk about 2-3 different ways. One is actually leaky gut. That is the most common one people talk about. And that one is a kind of a digestive condition where the intestinal lining allows bacteria and toxins into the bloodstream. So from the intestine, bacteria, toxins go into the bloodstream. Let me tell you, it is not a scientific term. So if you look into PubMed or something, they will not have a lot of articles on leaky gut. It will have intestinal permeability in it. So intestinal actual permeability is a functional feature of intestinal barrier, and it can be measured by kind of looking at the flux of solute from the lumen into the intestinal wall. And the last one is the protein losing enteropathy. We talked about leaking or actual permeability from the lumen into the intestine, but there can be also leakage from the blood into the intestinal lumen, other way. So that's mainly you lose the protein. So the term used is protein losing enteropathy. So we are going to talk about other two, leaky gut, but not talking about protein losing enteropathy. That itself is another big topic. So I explain my patients this way, that if you want to know what is intestinal barrier function or intestinal permeability, you think about Donald Trump, right? Everybody thinks about Donald Trump. So when you think about Donald Trump, you think about the fence or the wall, right? And it is fence or a wall, they are a little bit different. You know, wall is solid. It just doesn't allow anything to go through. And the fence is things that you can actually see through it. And that is very important. You don't want to be on the side of the wall and don't know what is happening on the other side. There may be 10,000 migrants trying to just cross into, or there may be nobody, or there may be somebody with AK-47 standing there. You don't know what is happening. So it's better to have something that you can see through. Why I'm saying this? The same thing happens in intestinal epithelium. We don't want it to be complete wall. We want it to be fence. We can see what is happening in the lumen and things like that. But if you look at the fence, and then actually you will know intestinal barrier function very well, and you will know the actual leaky gut. So the first one, this one you can see. Can you see it? This is almost solid. Nothing can go through. The top part has things that you can look through it. Now this was not made by Donald Trump. Okay, this was made by Netanyahu recently. This is the last picture that he did. This wall through between actually Gaza and Israel, complete wall now. And on the top of it, electrified, okay? So you cannot even jump through it. So we don't want to be like that, right? That is not in intestine. But if you look at the fence that we have, you can say somebody had cut through it. So the fence are not 100%. You can cut through it and you can then go through it even though you are not supposed to. You can see here, some fences are so wide open that people can go through between this stuff, right? They are not supposed to, but they will. And these two people are important because if they go through it, they are supposed to catch them, right? And then not shoot them, but at least catch them. Okay. So if we look at the kind of intestinal barrier function, it is like this. There is a fence and it can be broken. There may be some areas where the holes may be too big through which things can go that we are not supposed to go. But if all that happens, there are some people there, we call it lymphocytes and actually cells that fight off infection. They make antibodies and actually cytokines and they just take care of those. So when that happens, it creates a problem because there is always after effect or side effect of whatever war we are in or whatever happened, there is always some type of the collateral damage. So there will be collateral damage if these people start actually shooting and fighting. So the same way, the same thing will happen in the intestine. And those are the diseases. Now, if you have seen that this is the most active actually border, San Diego border, you know. This is the recent picture because they made it new, brand new. I mean, I have not gone through it yet, but you know, this is brand new now. And you can see there are different areas. Some of them are yellow, some of them are green. It means that certain people can go through this lane, certain people can go through this other lane. The same thing in the intestine. This one allows people to go through. The same way intestine is supposed to allow nutrients and other things to go through, but not the toxins and bacteria and other stuff. So we are kind of looking at similar thing that what all these different lanes are. So in the intestine, this is the cell that shows how the things go through it. There are many different ways it will kind of go through. The first one is simple diffusion. Diffusion is substance here is in higher concentration than here, so it will just go down there. Now it cannot go down just like that because the cell is surrounded by the cell wall that is made of the lipids and carbohydrate. So it has to be kind of soluble in the fat. So certain things will go through it by diffusion, simple diffusion. Other thing, there is a special kind of receptor, we call it. It will just allow only things that can fit on the receptor to go through it. And those are amino acids, glucose, things like that. The third thing is on this that's shown is that things can be sent out. If that kind of actually come in, it can be sent out through a different type of receptor. The one here is what we call endocytosis. It means that whatever is a toxin or bacteria or whatever is engulfed into this kind of actually circle around it, and then it will be pushed in, and there it will be taken care of by actually macrophages or lymphocytes or something. The one that is most important is, see, this is one bar, this is the second bar. Between the two, there is some space. That space has to be very tight so that nothing can go through it. That is the most important. Between two cells should not have any space. Otherwise, things can just go. Doesn't matter you have any of these things going on or not. So this one is a tight junction. If you want to just think about it, it is called tight junction, and we will talk about it a little bit later. What are these? But they are very important in preventing stuff from going from lumen into the intestinal wall. Right? Anybody has any question? Okay, they are still eating, I think. So let's skip this. So what is this leaky gut? You know, leaky gut is, as we talked about, there are actually barrier of the mucus, and above it is bacteria, mucus, and then intestinal epithelium and the blood vessel. If you look at the intestinal epithelium, these are the tight junctions. It holds cells together so nothing can go in between them. If you have problem in these tight junctions, you can see here, this cell, one of the cell is dead or infected or gone, whatever happened. Once it is gone, these tight junctions become loose. And when it becomes loose, things from outside can go in without any check. That's actually San Diego or El Paso border, you know. We cannot keep everything completely locked off or something. So things, once they go in here, they will be taken care of by blood cells here. But when that happens, it will create the problem. So what are these things that go through? They're bacteria, which are not good. Bad bacteria will go through it, virus will go through it. Some food item like gluten will go in there, that will cause the problem. So all this thing happened because that tight junction became loose and allowed things to go through it. So how can this intestinal actual permeability be changed? So normally it will allow only certain things to go, as we said before, but it will have problem in this microbiota. It means the bacteria are different, then it may alter the kind of intestinal barrier function. Second thing is the mucus. If there is a problem in the mucus, then it will allow things to go through it. The third thing is tight junctions, epithelium. That if there is a problem here, then it will cause the problem of things go through it. And the last is intestinal function of the lymphocyte macrophages and see if that gets affected. So we will talk about each one of them. Are you guys ready for it? Yes. Yeah, okay, making sure, because this is time consuming, right? No, we'll go very fast. So let's see. So first thing is, we want to know, is this intestine abnormally actually allowing stuff to go through rather than allowing only the normal normal actual molecules to go through. So there are many ways to look at it, but the most important thing you want to look is anything that is larger than the tight junction. If it goes through it, we can detect it in the blood or the urine. So we want to use something that can be taken up by the intestine, not normally taken up, but it is just goes through that open tight junction. Now tight junction, if you look at the size of it, is less than 6 Armstrong. You know what is Armstrong unit? So Armstrong is 10 to power minus 10 meter, or you know about the nanometer, right? So nanometer is 10 to the power 9. So this is even 10th times smaller than actually nanometer. That small tight hole is there. So any molecule that is bigger than 6 Armstrong, if it goes through, we know it is because the tight junction is not doing its work. So that's the theory. I will not like you to look at all the different things, but the one thing is you can kind of detect this permeability directly only by those kind of tests where you kind of give kind of somebody to drink actually molecule that is little bit kind of bigger and other molecule that is same or slightly smaller than the actual tight kind of junction. So there are two molecules. One is a lactulose. Everybody knows lactulose. Lactulose is used for constipation in babies and also those who are about 80 or 90 or something. Because lactulose is not absorbed at all normally. And it is about 9 to 10 Armstrong units. So if it goes through, it means it is absorbed. It means tight junction is not doing its job. And to control, because we don't have control when to collect the blood and other stuff, because it may stay in stomach for 2, 3, 4 hours and not go into the intestine. We will not know it. So to control it, we use another substance at the same time. That one is mannitol. Mannitol is absorbed through the tight junction area because it is slightly smaller than tight junction. It will go through. Most of it will go through. So you can see how much of the mannitol has gone through and how much lactulose has gone through, and you can just find out whether it is whether the lactulose has been absorbed more. So after you actually somebody to drink both these solutions, it goes from stomach into the intestine. So where it gets absorbed, but you see the smaller molecules. Smaller molecules are the one of the mannitol. These brown ones, mannitol. It will go through tight junction area also. While the bigger one, yellow ones, are the lactulose. It will not go through normally. Maybe very small amount sometimes may go through, but extremely small amount. So we know that lactulose will not go through. But how can we know that it has gone through or not? Is both of these are excreted in the urine right away. they are inert. Body has no function for it. So we actually collect the urine for 2 hours, and then you can collect second one. Sometimes people use it for 5 hours, 2 hours and 5 hours both times. And then you see the ratio of the lactulose versus mannitol and see whether it is high. If it is high ratio, then more of lactulose has gone in, intestine has become more permeable. So there are actually, other than mannitol, other things people use. So normal value is actually dependent on the lab, it does, so that you have to look at the reference range of that particular lab. And so this normal is, lactulose about percentage excretion is 0.35. It means only this much percentage of the actual lactulose gets excreted in the urine, 0.35, extremely small number. Mannitol, on the other hand, 12% or so. So you do the ratio of these two, lactulose over mannitol, normal is less than 0.03. If it is more than 10 times of that, we said, and then with time and everything else. But we have to know that, I mean, this is the way you can tell that intestine has become more permeable. So, I mean, should we do this testing? I asked our most senior gastroenterologist here, Dr. Garde, and asked, did you at any time do this test or even kind of think about doing it? And this test is available for a long time. Lactulose mannitol has been in for ages, before I was born, and I wasn't born yesterday. So these tests have been available for a long time, but it is not required for routine patient care. That's the thing, that we don't routinely do this test. But it should be done in some cases of food allergy, celiac disease, Crohn's disease, or IBD, or type 1 diabetes. I want you to keep on this type 1 diabetes, because it is an autoimmune disorder. We think it may be precipitated by the bacterial toxins that cross the intestinal barrier, and then they start this process. The same thing with celiac disease. So important is for any of these, if they are in high-risk group, it means patient already has celiac, then we don't need to do it. But if they are in high-risk group, then you can do the test. And if they show increased permeability, even though they are asymptomatic, they are more likely to develop that disease. And there are actually reports of this, and people not kind of normally do it. I have just put one thing here that this was done in a kind of family of the actual father who had actual Crohn's disease. They did studies in children. Intestinal actual permeability, one had high but asymptomatic. 8 years later developed Crohn's disease. So it can be very, very early sign of maybe developing disease down the road. So now we are going to talk about what makes intestine more permeable. We said that these are the 4 things, microbiota, change in mucus, change in epithelial cells. So first thing is bacteria. We have a lot of intestinal bacteria. We have a lot of bacteria in our actual GI tract. If you compare it to our own cells, compared to all our cells combined, that includes RBCs and platelets and everything in. Compared to that, the bacteria are 2 to 10 times more in number than our own cells. So they actually are the main people in this body. We are not in majority. They are in majority here. But they are important for the actual defense against other actually pathogenic bacteria and toxins. They are important development and maintenance of the immune system in the intestinal tract, and it can support the digestion by actually supplying some enzymes that they have, bacteria or fungus has, and we don't have. Or they also, some of the metabolites may be helpful, and the one is short chain fatty acids, other is vitamin B12. Bacteria make vitamin B12 and vitamin K. We know all these things. They are made by bacteria, and that kind of helps us. So these are the main functions of these actually bacteria. Now when we look at the bacteria, they are actually different in different places, and we are not going to talk about mouth and stomach and other things, but mainly we are talking about intestine and the colon. You can see intestine have villi, colon do not have actual villi, they just have the crypts like this crypt, and they have multiple type of bacteria, but if you look intestine versus the colon, intestine has less number, colon has more. And then we'll just kind of talk about other parts kind of later, but one thing is when you have these bacteria, they are not allowed to enter the intestinal epithelium. They are supposed to remain in the lumen, not go in, because that will cause the problem. So if we look this layer of the mucus, this is thick layer and this is the thin layer of the mucus. And in the mucus they have a lot of different other things. Immunoglobulins, most important is secretory IgA that actually protects against intestinal bacterial infection, and some other actually cytokines. All those are in this part that kind of prevents this bacteria from going in. This thick layer of the mucus prevents many bacteria from going in. It is just so thick that bacteria cannot go through it. Now there are some good bacteria and bad bacteria that we'll talk a little bit, but thing is, we want to make sure that all this remains in homeostasis. They all are in check. So what are these intestinal actually bacteria? So there are mainly three types. One is normal bacteria, we call it. They are helpful, or they are at least not going to cause any damage or any problem. The second one are bacteria they are waiting for the chance to invade the epithelium, opportunistic bacteria. Those are actually, you know about C. diff, I mean, that's actually one. And last one is the pathogenic. It means even small number of them are not good. They will cause intestinal infection like Salmonella, Shigella, Campylobacter, those bacteria. So there are three types. We would like to have more of these normal. We would like to have some maybe, but they have to be kept in check so that they don't overgrow and cause problem. We don't want any of this, otherwise it will cause problem. So if you look at the good bacteria, people now call it many times probiotics. So there are many different types, but the one that you have to remember is Lactobacillus, Bifidobacterium, and there are some other, and one of the one I want to put in there is the Saccharomyces fungus. That is good in the intestinal lumen. So what will cause this disruption of this bacterial kind of colonization? What will happen? We call it dysbiosis. It means that bacteria have changed. They are not the same way we talked about normal bacteria and some bad bacteria kept in check. When that balance is altered, then it will cause problem. So first thing is any antibiotic will cause some bacteria to be killed, and other bacteria that may be resistant to that antibiotic will overgrow. So that can cause a problem. So antibiotic use. Second thing is lack of the prebiotic in the diet. Prebiotic is the things in the food that help bacteria to grow. They need nutrition. They need to eat something, right? So the thing in the food that cause them to grow well is the fiber. Actually, fiber is not digested, goes in the colon also, and that's where it gets fermented, and that is their food. So if you lack that, then there could be dysbiosis. Other is excessive amount of certain sugars will cause the problem. The third, next is intestinal infections. Norovirus, rotavirus, all those are small bowel infections that will cause the problem of altering the intestinal bacteria. Chemotherapy and radiation, it will kill certain bacteria, not all, so that will cause problem. Other is frequent cleansing. Now people do this colon cleansing stuff, and they come to see GI doctor after 10 times they are done cleansing, and they will not even tell you until you do actually colonoscopy and there is some mild inflammation, and we know that this patient had been doing colon cleansing with enemas frequently, but they can also do oral cleansing. And that is a new thing now, that they will take oral medical laxatives and other stuff to get cleaned out once every month or once every 2 weeks or something. That will alter the bacteria because the bacteria get flushed out more rather than staying in. So other thing is the stress. And stress is both physical as well as actually psychological or emotional stress. Both stress tend to alter the bacteria. And how do we get this bacteria in the first place in the intestinal tract? Is as soon as the baby is born, we know they have some bacteria, and those bacteria are dependent on during the birth kind of process. What bacteria they can get encountered, and they just swallow those, and that may be the problem, that mother may have abnormal bacteria, actual colonization, and so the infant is not going to get regular one. He will also get the same abnormal actual bacteria. So we are going to talk about what to do with it later, but once we go to the next layer. Next kind of problem after the bacteria is the mucus. The mucus is very important in preventing bacteria from going in. And if you look, mucus is present from mouth to anus throughout, but the amount changes. And mucus is formed by the goblet cells in the intestinal epithelium. And in the upper small intestine, there are very few goblet cells, only 4% of all the cells. While you go to colon, it's almost 16%. So as you go distally, go down, then there will be more and more of those goblet cells. They will be making more of the mucus. And important thing, what does it do? First thing is it's source of nutrients for the bacteria. Bacteria use mucus. They eat that mucus. The second thing is there are gel-forming mucus, which makes a gel that prevents bacteria from going through it. And the last, that will make it a diffusion barrier. It will not allow anything to go through that thick layer of the mucus. Now, you want to make sure that this mucus is not kind of static. You know, that as we go from stomach to the actually colon, there are increasing kind of number of bacteria you see, but also you see the changing amount of the mucus. In the kind of stomach, there is 2 layers. In the upper small intestine, most of it is a thin layer of the mucus. In the mid small bowel, jejunum, ileum, you see little more kind of layer of the thin layer, but not much thick. It's only in the crypts. But in the colon, again, you see a lot of thick mucus and then large number of bacteria. So these all depends on the location. We are not going to talk too much about how the mucus is secreted, but if you see the change in the mucus, that will cause the bacteria to go through. So in the small bowel, there are, this is lumen bacteria there, and there is this mucus layer, but it has IgA and other peptides that will kill those bacteria. They will not allow the bacteria to go through here, so none of the bacteria will survive and will not be able to go through. While in the colon, there is thick mucus layer, prevents bacteria from going from the actual lumen near even the epithelium. None of the bacteria will be able to go unless this layer is affected. And that is an important source of the bacteria to go through. So there are some actual bacteria that will make more mucus, and there are some bacteria that will decrease the layer of the mucus. And decreasing the layer of the mucus is important in some way because it will allow the flow of the mucus, and it will continuously keep on going and not get stuck. Because if the mucus gets stuck, then that itself is a problem because bacteria will then be actually sitting in there for a long period of time. So important thing is all these bacteria, how they help is by actually making short chain fatty acids that will help the mucus layer remain intact. Now there are some that will cause actual degradation of the mucus. It means mucus that is already formed, it will be degraded, and those are actually pathogenic bacteria, cholera, giardia, amoeba, and there are some actually helminths, worms that will cause more actually kind of destruction of the mucus. Then there are some who will decrease the mucus actually production by the goblet cells, and there are some which will increase the mucus secretion, and those are actually lactobacillus, bifidobacteria. Therefore, they are called good bacteria, actually probiotic. Is this because they will stimulate mucus actually production and actually they will also restore mucus growth. So these are some bacteria that are good, not themselves, but they are good because they help make more mucus. So this mucus layer will be decreased in those who have loss of goblet cells, because those are the ones that make the mucus. So it has been shown mainly in ulcerative colitis that they have less number of goblet cells. Any infections, because it just kills off the epithelium, then the goblet cells are also gone with that. Dysbiosis, we just talked about the bacteria. Different bacteria will cause the mucus layer to be decreased. Certain thing in the diet. The first thing is decrease water intake, and we say that make sure that there is no dehydration of the mucus, because once it gets thicker, then it will not flow easily, and that will cause the problem. Most important is emulsifiers. We say processed food, don't eat processed food. Why? Because there are a lot of things, but one is actually cellulose, polysorbate, maltodextrin, benzoate. You will see this in processed foods. What it does is decreases the actually mucus, causes mucus to be degraded. Pesticides, heavy metals, nanoparticles. You know, now you talk about all these plastics that has been in some spray aerosols, and that can also cause kind of problem with the mucus. Again, frequent cleansing, it keeps out the mucus. Then there are some genetic disorder where they cannot make the mucus. Mucus is made by the actually glycosylation kind of reactions. And last is thick or viscous mucus, which is in cystic fibrosis. You know, cystic fibrosis patients have thick mucus. Not that it is good, it is actually bad, because the bacteria just sits there, goes through it, because it is not being flushed out. Mucus is continuously secreted. Actually, in 8 hours, if all the mucus is gone and the new mucus starts again. So it has to keep on kind of going. And the last one we are going to talk about that alters the permeability is the change in the tight junctions or intestinal epithelium problem. So if you look, the tight junctions, we talked about a little bit about before. This is a very, very special fence. You know, Donald Trump has to look at this and see, this can make nothing go through. You know, that's the problem. That's the most important thing. There are two types of tight junctions, chlorine and occludine. But see, once it is tight, nothing can go through except very small molecule. Very small molecule will still go through it. And those we talked about, one is the mannitol, but most of the bacteria, toxins, they are larger than this. They will not go through it. So what can cause the problem of tight junctions to be loosened? So you can see the tight junction here, this is very tight, made loose, opened up a little bit. So things can go through it without any problem. And these are made tight by actin. This is actin, and that may be problem either with actin or with this junction or actual structure of those tight kind of junction itself. So if I just show you one thing, these are all bacteria in the mucus, intestinal lining. This is actually goblet cell making the mucus, and something can go through here. But here there are tight junctions, 3 different places. Will not allow anything to go unless there is some damage. Then all these things that are here can go through it here, and here it will cause the problem then. And that's the in the lamina propria below the epithelium. So they have actually shown this in IBD colitis patients, ulcerative colitis patients, that when they are inflamed, we don't know whether this is cause or effect, but they have intestinal actual permeability that is marked, and that allows this bacteria to go through. And some of these bacteria will then actually interact with lymphocytes, and they will then kind of develop antibodies, and that will cause the problem. Now, thing is, as long as they stay there, it's not going to cause systemic problem. But these are drained by lymphatics that will go into the lymph node and then the systemic circulation. And now the theory is that these are the things that causes mild chronic type of kind of actual reaction in the body and cause all these autoimmune disorders. Autoimmune disorders are thought now that is secondary to this effect. And we'll just talk about what else. So what can cause this tight junction to be dysfunctional? One is definitely epithelial damage of any kind will do that. So first thing is infections. We call it gastroenteritis, but they will all have that. Now, the thing is, it takes 3 weeks for cells to heal completely. From the crypt, bottom of the crypt, to go up to the top of the villus, it takes 3 weeks. And during that time, they are very permeable. So you want to make sure that 3 weeks after the acute intestinal infections, there can be still increased intestinal permeability. So we call it post-infectious enteropathy. That after the infection has come and gone, but the damage left by has not healed, and then you did something that allowed the cells to continue to be affected. Again, IBD, Crohn's disease, ulcerative kind of colitis patients, celiac disease, it is both the cause and the effect. Malnutrition, very important. It is not just overall malnutrition, but carbohydrate or protein malnutrition, vitamin D deficiency, zinc deficiency, all those cause tight junction to be dysfunctional. Radiation chemotherapy, and last is ischemia. There are like many causes for ischemia, mainly in the older people, but this can alter the tight junction. So what will happen? Now you ask, okay, intestine is more actually permeable, so what? What will happen? So there are 2 types of problems, intestinal problem and extra-intestinal problem. Intestinal problem starting from gastric ulcers, or diarrhea, irritable bowel syndrome, inflammatory bowel disease, celiac disease, some cancers. While extra-intestinal is allergies, important, because intestine did not keep that actually offending allergen in the lumen, allowed it to go through, that then set off the reaction. So like actually eczema, asthma, they may be related to some food because of allergy that intact food particle went through. Respiratory infections, sepsis, multi-organ failure is thought to be secondary to bacteria going from lumen into systemic circulation because of increased permeability. Inflammation, including arthritis, rheumatoid arthritis. And CV Mehta, Dr. Mehta just woke up, right? I said, treatment for rheumatoid arthritis is send them to GI doctor, right? And then we take care of them, right? Yeah. No, but I will show you some kind of little bit data about it. And the last is very important. People now talk about is obesity-related problem. Obesity related to intestinal barrier function. And they may be related to change in bacteria, dysbiosis, and other stuff. So what it can do is it can cause problem in multiple organs. Increase intestinal permeability in the liver from the obesity, NAFLD, NAS, cirrhosis, in heart failure, chronic lung disease. Now they are actually working a lot on the gut-brain axis and see the problem. And that depression, schizophrenia, chronic fatigue, autism, Alzheimer's. I think I should show this to RFK. He will be very interested in this, right? Because he thinks vaccine causes it. No, it is this intestinal permeability that causes this problem. Now, renal failure is if they already have a renal disease and then there is bacterial translocation that can actually precipitate renal failure. And type 1 and type 2 diabetes and severe acute pancreatitis. Those are associated with increased intestinal actual permeability. So I'm going to pass how does this happen. But most important is the diet. That how can the diet alter this? So it is a Western style diet or Western diet. Western diet doesn't mean California diet, okay? California diet is better than eastern part of Western world, that you want to think about it. But the thing that is energy-dense food. Energy-dense food means very high calorie foods. The small amount you eat and has a lot of calories. Those are the ones that are actually problem because it will have a lot of unabsorbable sugar or fat that will then alter the bacteria. Or malnutrition, inadequate energy balance. It will cause change in the microbiota. It will then lead to obesity, joint disease, depression. Other is translocation of bacteria. It means the bacteria have gone from intestinal lumen into blood, and then it will cause enhanced endotoxin that will go into the portal vein first. Portal vein goes to the liver first, and the liver is a filter that will stop everything going into systemic circulation. It will cause low-grade liver inflammation that can lead to NASH, insulin resistance, that's type 2 diabetes, and metabolic disorder associated with obesity. So I think the best thing you can do now if you are in medicine is become a gastroenterologist, because all these things are happening because of that. Right, Dr. Garde?
So I have one question. So
Yeah.
Is study proven there? Or
Yes. These are all proven by studies. I don't have time to go each one of them for the studies, but yes, these are proven in the studies. So they may be small, but there are some actually population-based study that shows the problem. The problem is you cannot do intestinal microbiota in everybody because it is very expensive still, because there are so many things. So you look only at few bacteria and see, are these the problem? And they then compare this bacteria in obese versus non-obese. And it has been proven. So if you just go on Google and YouTube, what to do with intestinal bacteria and weight loss, they will say take fecal enemas from a thin person. We know that somebody says that you eat so much and you still not gain weight. I'm not talking to you, Raju bhai, but there are some who say, I just breathe air and I gain weight. Why? Because they have different bacteria in their intestinal tract. And people say that you take the intestinal bacteria from a thin person, transplant it into an obese person, they will start losing weight. Now, doctors don't believe it many times. But people believe it, so they started doing their own enemas, fecal enemas. If you go on YouTube, it will tell you 100 different ways of doing fecal enemas, how to collect the stool from a thin person and how to get it in your system. It's very simple to do if you want to do it, but I don't like doing it. We actually did fecal transplant in C. diff patients, those who were transplant patients and had kind of recurrent C. diff problem. We did in kind of those patients, and it's very cumbersome to do. So we decided not to do it now. And it has been proven. So all these things I'm saying is not just taken from New York Times, but from some actual studies that have been done. So these are the things that says from where I took this data. I didn't want to read all these things, but these are the things that it says, how was it done and where it was done. So gut-brain axis we talked about, it causes a lot of other problems. And last is autism, that kind of people say that is associated with change in bacterial kind of translocation when you have kind of leaky gut. And for the lack of, now the last one is actually COVID, the prolonged COVID. The COVID, everybody thinks COVID causes problem in the lungs. COVID infects the intestine first. It is thought that maybe the intestine that's the first problem. But if you want to know COVID, whether say any person has COVID or not, you go ahead and do NP swab, right, and look for. Right? COVID is gone from there. It is not there anymore. There are no symptoms. But if you check the stool for COVID-19, it may be positive. And we know that excision continues for a long time. So if you are in China, they had, during this COVID time, they had city after city isolated completely. How did they know there was COVID there? They go into the big apartment complex. There are like 10,000 people in that complex in China. So they go and collect the sewage. The main pipe coming out of the apartment complex, they just check the sewage. If it is positive for COVID, all 10,000 got stuck in that complex. They can't find who has it, but somebody has it. So intestine will continue to secrete COVID for a long time, and it is thought that it may be one of the reasons of prolonged COVID. I'm not going to go into detail of that. That's a study that was done. And it's also the cause for thrombophlebitis or hyperactive coagulopathy occurring in COVID related to intestinal permeability. So I'm going to skip some of the things, except I want to show one slide to Dr. Mehta to say that there is, how can intestinal bacteria cause arthritis, right? So this is the one that shows that how it happened. We call it gut joint axis, gut brain, gut joint. So these bacteria have, when they go through these intestinal cells that are more permeable, they will develop antibodies from this lymph node, and it may then go through the lymph node into the systemic circulation, and many of these bacteria or bacterial toxin has actually affinity for the synovium, so it will cause synovitis. Now, in my study, I've been pediatric GI for a long time, almost 40 years, and in past, any IBD patient that complained of joint pain, we gave them antibiotic, because we know that it is the intestinal bacteria that causes translocation of toxins or bacteria that causes joint pain. So arthralgia is one of the common symptoms of Crohn's disease patients, and it is thought to be purely related to the toxin from bacteria. And you kind of treat intestinal bacteria, their joint pain get better. And the things are coming back now. By the time I am retiring, the same things are coming back, you know. But that it can affect so many different organs, not just the joint and brain, but also the skin. We talked about skin, the skin gut axis, lung gut axis. All these are secondary to effect of bacterial toxin or bacteria themselves translocated, causing the problem. So what should we do now? And there are some, how about like kind of different foods cause the problem? We talked about certain things in the diet, emulsifier. Emulsifier will affect the mucin. It will just degrade all the mucin. It will just slough up. I mean, that's its job. Emulsifier are everywhere. And you think about it, and it has actually emulsifier. They help actually stabilize the solution or stabilize the suspension, including toothpaste have emulsifier, and canned food have emulsifier. All those have emulsifiers that will affect this. So I'm going to skip some diet stuff. One thing that in the diet I wanted to make sure is, one, in the middle, alcohol. Alcohol also will affect the intestinal permeability. So what should we do with this? So we say, how can we support intestinal barrier function? So there are like many approaches. First thing is the diet, obviously. The avoidance of high amounts of processed food. That's first thing. You can have some, but not a lot of kind of food that has emulsifiers. Sugar and saturated fat, because this will alter the bacteria in the colon. And polyols. Polyols are actually carbohydrate, but alcoholic carbohydrate. So these are the ones that are actually sweeteners. We cannot digest or absorb it, and that causes the intestinal bacteria to be affected. They are in all chewing gum, candies, all those things that we eat, and says 0 calorie. It is xylitol or sorbitol. It is sweet, but very, very few calories. Avoidance of energy-dense Western style diet. Low FODMAP diet. You know FODMAP, many of you might have heard. It is the fructose oligosaccharide, disaccharide, monosaccharide diet and food. So those are what we call simple sugars. That will cause the problem. Now, FODMAP is important, but those that if you don't digest and if they go in the colon, it will help bacteria grow more. And so they are helpful in some way. So you cannot be on that diet for too long, low FODMAP diet. So now recently they started having an enzyme to digest these FODMAP foods, and that's a FODzyme containing that contains some enzymes. And you might see some ads soon about it Another thing is prebiotics, fiber, turmeric. That will help make the tight junctions tighter because of its effect in the actin. Important amino acid is the glutamine. Glutamine is considered the source of the protein for enterocytes, especially in the colon. Vitamin D, vitamin A, and zinc, these all are important for epithelial growth. And other is avoid gluten and casein, that is milk protein, at least during and up to 3 weeks after any intestinal infection. I tell that to all my patients, and they say, why should I avoid gluten? But it can sensitize you because it has now increased permeability. So you want to make sure that you stay away from this for 3 weeks. Other is a probiotic, probiotics that are important, lactobacillus bifidobacterium. You want to make sure they are in large number, more than 10 billion CFU, colony forming unit. So don't go ahead and look 500-600 million bacteria. They are not going to be important. They are not going to work. You need large number, large amount of it. And if you go and look in many of these currently available probiotic, it will say 1 billion. But that is not it. You need more than 10 billion of those bacteria. VSL number 3, it has both of these plus streptococcus, and it's the only FDA approved probiotic. It is considered medical food. No other probiotic is FDA approved. It is not considered medicine, it is considered food. So there is nobody looking over those people who manufacture those. You don't know how many of them are active bacteria or not. They may be all dead bacteria you are eating, and they're not going to be helpful. And last is the yeast, Saccharomyces. Yeast that is used in baking, to make bread, and this, they call it baker's yeast. That is good. That will help the bacteria. And in immunocompromised patients, those who have transplants and those who are on immunosuppressive medications, premature infants, or if they have foreign body in their systemic circulation, then stay away from too much of the probiotic. Because those bacteria can also translocate, and once they go into the systemic circulation, it can get attached to those cells. So some of the cardiologists might tell you, I don't know anybody here, cardiologists, that recommends no probiotic, but there are some. And I know the pediatricians, there are some actual formulas that contain some probiotic, but should not be given in any premature infant. We stay away from it because it can cause infection. Sometimes people use probiotic cocktails, and that are made from yogurt. So mango lassi is good, It has something, and mango has good fiber, and so it's a good food today. Okay? Go ahead and have some. Yakult is type of an yogurt. Kombucha, if you can stand the taste of it or smell of it. Okay, I can't. I will not like to even put a teaspoon in my mouth of kombucha. It's so sour, but more sour it is, more fermented, more bacteria in there. Okay, so that's one thing. And other is ginger beer. Again, it is fermented, therefore it helps. When you kind of combine probiotic and prebiotics, that's some foods that we call symbiotics. There are some other drugs you can use to make intestine less permeable. One is short chain fatty acids. Short chain fatty acids are the source of fuel for enterocytes, porocytes. Again, I am talking about like 30 years ago. Ulcerative colitis patients, we didn't have all the modern medications. Only thing we had was prednisone, steroids, and then sulfasalazine, only 2. And we think that sulfasalazine worked because of the sulfur component killing some bacteria. There are a lot of things. So those times, people were giving fatty acid enemas to these proctitis colitis patients. You cannot take it by mouth because it will be kind of degraded and absorbed. Other one is the chloride channel and a substance lubiprostone. We use it for constipation, but it can make more active chloride channel that will make tight junctions more tight. And there are other kind of plant pigments, so green, red, anything that you see, vegetables, they have those flavonoids, they are helpful. So I'm going to actually stop here because I know people may not, yeah.